I'm audible. A very good morning to all of you. The participants for this short course on diabetes for nurses. Today is the sixth day that SRM Trichy College of Nursing is organizing this program. Today we are blessed to have Dr. Arvind with us. He's a general physician. Sir has done his MD General Medicine at Arupadai Veeda and he has joined here in SRM Trichy Medical College and Hospital. We are very happy to have you, sir, amidst us. And today, sir, will be specifically dealing with us on the medical management, that will oral hypoglycemic drugs as well as on insulin therapy. So over to sir for the next half an hour, following which we will have a presentation on diabetic ketoacidosis by Mrs. Sharmila, the Associate Professor of SRM Trichy College of Nursing. Looking forward to listen to you, sir.
Very good morning to everyone. Thank you for the brief introduction for me, ma'am. I hope everyone can hear me. So first of all, going with the slides. So first of all of you would have heard about the normal, how you call a diabetic drug is oral hypoglycemic agents. So that is not the true thing. So now the ADS criteria has been recently announced. For past 3 years, it should be called only as an anti-diabetic agents. There's no any terms called as oral hypoglycemic agents. Going with diabetes, I hope they would have given you a brief about how to diagnose a patient with diabetes, type 1, type 2 diabetes particularly. So you nurses should take proper care in diagnosing a patient. Not only the medicos or doctors are responsible for diagnosing a case of diabetes, even by you. So you will be the one who will be collecting all the reports and all over getting a sample for a patient properly. So you should definitely know how to diagnose a case with diabetes. So first of all, what you'll ask whenever, not only for the patients, someone in your relative can also be having diabetes, right? So you should ask them to do basic investigations for them. So what will be the first basic investigation? Never go with the fasting glucose immediately. So the most important basic thing that should be done for a patient to diagnose diabetes is a random blood sugar. Even a random blood sugar for the diagnosis of diabetes patient, when you take a random blood sugar, if it is more than 200, there is no need to go with any FBS, that is fasting blood sugar or postprandial blood sugar or HbA1c. Patient having a random blood glucose of about more than 200 milligram per deciliter with symptoms of hyperglycemia. So what will be the symptoms of diabetes? The patient will be having increased amount of urination, increased amount of thirst they'll be having. So they'll be having polyuria, polydipsia, they'll be having excessive thirst along with excess intake of food. So these are the most the complaints that the patient will be having when they are having symptoms of diabetes. So patient having these symptoms and along with random blood sugar of about more than 200 milligram per deciliter is diagnostic of a diabetes. That is according to the ADA criteria. So once the patient is having random, doesn't mean that you have to go with only a start initially treatment. So some patients would have had a very increased intake of food in the previous day night. So without symptoms. So it doesn't mean, okay, the patient is having random of more than 260 or 200, you start immediately the drugs. No, it is not like that. So always go with the protocol. First of all, the basic protocol to do with for diagnosing diabetes is once you do the random, next ask for the patient to do come with a fasting stomach, that he should be having a overnight fast. So hopefully he should not eat a very high intake of food should not be done the previous day night so that it doesn't alter the fasting blood sugar values. So always ask the patient to take a proper normal diet. Soft bland diet is better. So after that, following that, patient should be taken for fasting plasma glucose. So that for normal glucose tolerance is less than 100, as I give the slide shows you clearly. So pre-diabetic stage, what we used to tell is 100 to 125. But most commonly, the diagnostic range for a diabetes and fasting level is it should be more than or equal to 126 milligram per deciliter. That is more important. So once the patient is having fasting, so next you have to do is the OGTT, that is oral glucose tolerance test. So how you do that? You will be giving about 75 grams of glucose is dissolved in 300 ml of water after an overnight fast in persons who have been receiving at least 200 grams of carbohydrate daily for 3 days. So actually, the protocol is give 75 gram of glucose in 3 ml of water. A little bit louder. Okay. So always get 75 grams of glucose in a 300 ml of water, and after that check the postprandial after 2 hours. So if the postprandial glucose is more than 200 milligram per deciliter, it is also a diagnostic condition of diabetes. Mostly we used to do with only these two tests, but what we physicians prefer for the control of diabetes is not only the fasting, is not only the postprandial. Our target is to maintain the HbA1c. This is the more important thing that to be controlled in a patient with diabetes, because that plays a major role than the fasting or the postprandial. So HbA1c should be always maintained. Your target, if a patient is having HbA1c of more than 8 or more than 9 or more than 10, the patient should be severely monitored, and based upon the HbA1c you should do the treatment. So HbA1c will be your main target. So patients with diabetes, having a known diabetic, he could be a diabetic for more than 10 years, so their target HbA1c should be at around minimum at least at around 7. So the patient will not be having any diabetic complications. Based upon that, based upon the level of HbA1c, the patient's complications will be going on. So diagnostic criteria for diabetes based upon HbA1c will be more than or equal to 6.5. Never forget that. So fasting is more than or equal to 126, and 2 hour, that is after 250. So after 75 grams of glucose, the patient's sugars will be around more than 200 or equal to 200, and HbA1c should be more than or equal to 6.5. These are all the diagnostic criteria for diagnosing a patient with diabetes. So I hope they would have given some brief about how the patients having diabetes, what are all the complications of diabetes. Some DK will be discussed with the other doctor. I'll be dealing only about the how and when to start the proper medications for the patients. In India, this is the national disease of the world. Particularly for India, it is national disease, because even if you screen around 100 people at the age of more than 60, you'll be getting around an average of around 40 to 50% of the people will be having a diabetes at least a pre-diabetic stage will be there. So it is always very important to screen all the patients who were at the age of 60 or even 50 years, more than 50. It is always, you should advise the patients to go for a screening of diabetes. That is mandatory for all the patients. So going with the classification of the oral hypoglycemic agents, that is the anti-diabetic drugs. First of all is the sulfonylureas. What you'll be giving is, it being classified as, can be the first generation, can be a second generation, and the third generation is called meglitinides. And second one is called the sensitizers. They can be biguanides and thiazolidinediones. These are all the drugs which has been classified. I'll be explaining each and every drug and what is the side effect for each drug and how you have to give it and what time you have to give it. I'll be explaining you. So going with the third classification is the alpha glucosidase inhibitors. These are peptide analogs. They can be incretin. Incretin is a hormone that is being secreted in the stomach. So these are like glucagon-like peptides. They have GLP analogs and agonist, and another one is gastric inhibitory peptide. And there is a newer drug called as DPP4, that is dipeptyl peptidase 4 inhibitors. I'll explain that also in the next upcoming slides. And final is the amylin analogs. We have the newer classification that is being started nowadays, which is called as SGLT2. I'll explain that also in the last slide. It is nothing but sodium glucose co-transporter 2. This is the recent oral antidiabetic drug that is being under practice, but due to certain side effects, we are not advising for many patients, but it depends upon how the patient needs. So how you classify sulfonylureas? I hope when you see many patients in your family, even they'll be having either what is the most common drug you'll be giving us nursing. When you come to the practice, you'll be giving definitely patients with you'll be dealing with particularly the second generation drugs like glipizide, glibenclamide, glimepiride. These are all the commonest drugs you'll be using. So I'll be dealing only about these drugs in detail, because these are the commonly used drugs. Going with tolbutamide, chlorpropamide, acetoxamide, and tolazamide are all are being used under practice now. But most commonly, glibenclamide and glimepiride. This glibenclamide is being commonly given in our government as a free tablet, right? Whenever you see a patient coming with, sir, this is the drug they have been giving, I've been taking regularly from GH. So if you take and see that, if you take and try to see the name of the drug, it will be glibenclamide most commonly, because that is the cheaper drug which is being given as free in cost from the government. Another drug that is the best ever anti-diabetic drug that is being found till now is only one, that is metformin. It is a basic drug which should be started in a patient when you diagnose them as diabetes. So never forget, the first drug of choice is always metformin, because this is the only drug which is proved that the patient will not go for hypoglycemia. There is never a record being showing that the patient on metformin will be having hypoglycemia. Hello. So the patients on metformin have to be seen other meglitinides analogs, that is called as reparinide and tiaglinide, and the fourth one is thiazolidine dipeptide, and last one is alpha glucosidase inhibitors, that is called as acarbose meglitol. Why you want to give the drugs, anti-diabetic drugs? There should be some role, right? Doesn't mean that anyone can give a drug. So if he's having diabetes, so start this drug. Doesn't that mean like that? So what will happen? So how the patient is going for hyperglycemia? Why they're having this? Once hypoglycemia is happening, what will happen? The carbohydrate load. Once the patient is taking increased amount of carbohydrate, some patients will be taking about large amount of rice. You know, in India, particularly in the south side of Tamil Nadu, South Tamil Nadu itself, most staple food is rice. So what people will do, they'll take 3 times also rice. Morning also they'll be taking rice, afternoon also rice, at night time also rice. That is the main reason for patient ending up with diabetes. So what will happen? There is increased amount of gluconeogenesis is happening in the liver. So that is the main problem. So what will happen once the glucose production is more? Patient go into hyperglycemia. Not only that, most often the people taking increased amount of carbohydrate, what will happen to them? They'll be a little bit obese, right? So because of the increased amount of fat that is being stored in the body, they'll be having adipose tissue, that is increased amount of free fatty acids or more. So that is also the reason for hyperglycemia. Finally, just imagine patient taking large amount of diet, increased carbohydrate intake, large amount of glucose. So the beta cells that is being produced in the pancreas, they are not sufficiently working. So there is not enough amount of insulin being produced. So because of that, the patient end up into diabetes again. So each and every drug which is being given has a role. How to reduce the digestion of the polysaccharides. To increase the digestion of the polysaccharides, you have to give alpha glucosidase inhibitors that is being shown in the slide. And how to decrease the glucose production. So what will happen? That can be done with help of metformin and thiazolidinediones. And finally, how to reduce the fat, that is free fatty acid that is present in the adipose tissue, is using the thiazolidinediones, that is the drug. And finally, how to decrease the glucose uptake that is present in the skeletal muscles. That is also being done with the help of metformin and thiazolidinediones. So this is just a pictorial representation how to do an oral hypoglycemic agents. So the types, as I said, first type is the sulfonylureas. Don't go with the tolbutamide and the chlorpropamide and all is not being used commonly. But for you guys have to know about two drugs that are glibenclamide and glimepiride. So what is the duration of action? Just see the duration of action. Glibenclamide is having around 1 day of action. So it can be present for 24 hours along with glimepiride. Frankly speaking, more than the insulins what you're going to give to the patient, oral anti-diabetic agents are more severe to cause hypoglycemia. So patient will be having fear of hypoglycemia. When you ask a simple patient, just ask it commonly to a patient who's on glibenclamide, ask them whether they are having any giddiness in the early morning. Most of the patient will be telling, yes sir, I'm having giddiness. I'm not able to concentrate. Early morning, I'm feeling very tired because of the only drug is glibenclamide and glimepiride. Proper dosing is needed for these patients who are on glibenclamide and glimepiride. Because more commonly, these patients, what they'll do, they'll be taking either a BD dose or OD dose. So once they take the BD dose, what they'll do is they'll not eat properly at the night. Before going to sleep, what will happen? Just imagine this drug is having duration of action for about 24 hours. Taking this drug and the patient is not eating at night. So just imagine there will be more amount of action. The patient is going to severe hypoglycemia in the early morning. So that is the main problem that is being noted with these patients. So how it is being given? It is usually given just before along with the meal. Moderately, it is protein bound and it is metabolized in the liver, and few are metabolized to active metabolites. They have low volume distribution, and there sometimes some amount of the particles are being unchanged in the urine. Even if you take urine sample, some amount of drug can be found. What is the most common side effect? As I said, hypoglycemia. It is the only dangerous side effect that can be seen associated with sulfonylureas. So these are long-acting drugs, which is dangerous and can be because of inadequate diet. They can be having renal hepatic diseases and other drug administrations. Along with that, the patient go up with hypoglycemia. Second, most commonly, what the patients will tell, sir, I'm having one thing. They'll be complaining of one common complication, one common side effect the patient will be telling. What is that? They'll be telling, I'm having GI irritation. That is what? Ulcers. So most commonly, patient with metformin or glibenclamide, glimepiride, they'll be having ulcer definitely because prolonged intake of these drugs will cause GI disturbances. And not all diabetics, they'll go into weight loss because type 1 diabetes, type 2 diabetes, I hope they would have discussed in the previous slides. Type 2 diabetes, most commonly patients end up with weight gain because these drugs cause increase in adipose tissue. As I said, even the free fatty acids are being reduced, but there is increased amount of fat deposition occurs. So as a result of that, the patient end up into increased weight gain. Finally, allergy. So what is allergy? More commonly, but we are not using this drug nowadays. Most commonest allergy that is found with chlorpropamide drug is called jaundice. When you see a patient with diabetes having jaundice, always check their drug history because some patient would be taking this drug and as a result of this drug, they would have had a jaundice. It doesn't mean that patient would have end up with some liver pathology. No, because of the drug-induced jaundice is more commonly with chlorpropamide. And finally, there is thyroid dysfunction, which is more commonly used because of tolbutamide, which reduces the iodine uptake. So this is why we are not using these drugs more commonly. Other than that, we are using second generation drugs like glibenclamide and glimepiride. So what is the drug interaction? So some patients, while taking this drug, particularly with the first generation sulfonylureas, if they are consuming alcohol, there is a very bad prognosis can occur. The patient will have poor control of diabetes. And how can you enhance the patient to take proper drug action? That can be advised by advising the patient to do high protein intake during each and every time. And the final inhibition of drug interaction occurs when the enzyme induces decreases duration of action. That is chronic alcoholism. Patient having chronic alcoholics, they'll be having hyperglycemia, and acute alcohol intake causes hypoglycemia for these drugs. And corticosteroids, a patient will be having on diuretics. Some CKD patients will be there, or any other cardiac patient will be there. They will be in diuretic support will be there, and those patients should be diagnosed and interacted particularly. And finally, is the beta adrenergic drugs which mask the hypoglycemia. This is the most commonest mistake. What they'll do, if you see a patient, they'll be on metformin, they'll be on the glimepiride or glibenclamide, but always check the patient if he or she is in beta blocker. That is the most dangerous condition. Why I'm telling is, just think about a situation. Patient is taking the drug at the night, he's not eating, and early morning he's having hypoglycemia. That is normal scenario. You'll know the patient has taken the drug, he didn't eat, that's why he's having hypoglycemia. Just imagine what if the patient is on beta blocker. What will do this beta blocker will mask the hypoglycemia, so the patient will not have any symptom of hypoglycemia. That is the most dangerous condition, because you will not come to an idea what is happening to the patient. So that is the most dangerous condition, because sometimes suicide can also occur. Most commonly what they do is, in homicidal also, they'll be giving patients with metformin, they load with metformin, and they'll take beta blockers. So what will happen? It doesn't show that the patient is being done a homicide. It looks like a suicide. Okay, so beta blockers can mask hypoglycemia. So always, we doctors, what we'll do, we always monitor the patient with oral hypoglycemic agents or anti-diabetic drugs. With a beta blocker, always give it a monitored dosage. So the next classification is meglitinide. These are secretion enhancer. Here the mechanism is similar to sulfonylureas, but the binding is different to the site of the receptor. So here the receptor is different when compared to the sulfonylureas. It has a rapid onset. It should be taken. Usually we ask the patient to take along with the food or just before the food. It is usually metabolized in liver, and the caution is, more commonly meglitinide has some liver damage can occur, so it may result in hepatic dysfunction. So always monitor LFT while giving a patient with meglitinide, and is mainly preferably we use these drugs to mainly to control the postprandial. What I said is, after some patients will be having fasting will be under 120 will be under control, but some patients postprandial, the same patient postprandial, that is he might be taking large amount of food, or his postprandial level is always the baseline, that is more than 180 or it is more than 200. We can preferably go with this drug because it has a very good response to postprandial hypoglycemia when compared with fasting hyperglycemia. And usually substitute in case patients having allergy to the sulfonylureas like glimepiride, glibenclamide. If they're having any side effects to that drugs, you can alternate with this meglitinide. Only initially, but know one thing, always the first drug of choice will be metformin, and next one will be sulfonylureas. That is the second generation sulfonylureas. That is either glimepiride, glibenclamide, or gliclazide. And the next drug of choice will be, I'll be explaining the other sites. If the patient is having side effects to the sulfonylureas, go with meglitinide. Metformin. Never forget this drug. This is the golden drug for diabetes. Mainly, it increases the uptake and utilization of glucose by skeletal muscle, which reduces the insulin resistance. So, whatever patients you see, they'll be on metformin, right? So, this is the only drug which is being approved, will not cause hypoglycemia at all. So, it will cause to some person, but patient with the higher dosage, the maximum dosage, if they are going beyond the maximum dosage, some side effects will be there, but hypoglycemia is very rarely seen with metformin. It mainly inhibits the hepatic and renal gluconeogenesis and decreases the hepatic glucose output predominantly. This is why we prefer this drug, and mainly slows down the intestinal absorption of glucose. So look how much benefits we have with this drug. This was the first drug which was diagnosed, which was used to treat diabetes, but till now it is having no drug has overcome this metformin, which promotes the insulin binding. So it mainly clears the liver and kidney glucose and does not decreases the absorption of glucose in the intestines. And moreover, it also promotes the insulin binding to the receptor. So it has many advantages, and also lowers. It has some good effects in dyslipidemia also. Just imagine a patient is having increased amount of cholesterol. Metformin will reduce the LDL level and also VLDL and maintains the good cholesterol. That is HDL is also be maintained in a proper manner when you give metformin. So it is usually partially absorbed and partially metabolized. Duration of action is around 8 hours. Usually what we'll do, we ask the patient, in practice, half an hour before food. We used to ask them to take before food, right? It can be taken with the food. It doesn't matter, but usually we advise, because in Indians, as Indians, we take more amount of carbohydrate rich food, right? So it is always better to take the drug before, half an hour before the food. And dosage is 500 mg It is actually the basic dose is 500 mg we used to start for a patient, but it can be depending upon how the patient is needing about, because maximum dose is around 2.5 to 3 grams. Till we can give it around 2 grams per day. But initially we used to start with 500 mg BD. So whenever you find a patient having fasting of around 140 and HbA1c is around 7 and postprandial is around 200, always go with metformin. We used to start with metformin at BD dose. Never start a rigorous treatment for patients with diabetes, because each and every body surface area varies, right? You will be having some body surface area, I'll be having some body surface area. My insulin dependent will be different, your insulin dependent will be dependence will be different. So always go in a leisure manner. Some patients will be needing large amount of this biguanides. It doesn't mean that immediately, okay, patients fasting is 200, postprandial is 300, we should start with 2 grams. No, it is not like that. Always go with protocol. Always go with the basic dose. Always start with 500 mg BD. Then you have to taper the dose depending upon the insulin monitoring, depending upon the glucose monitoring. You should increase the dose. It doesn't mean that within a week you should increase the dose. No, it is not like that. First of all, before starting, advise the patient to start a proper diet. Without proper diet, whatever drug you start, it has no use. That is the first thing. And advise the patient to have moderate activity. They should be walking. They should undergo walking at least for half an hour a day. At least for half an hour, the body should start sweat. Sweating is the most important thing to reduce the glucose. So advise the patient to have a proper diet. And second one is advise them to go for a proper walking. Even after having proper diet, even after maintaining a proper BMI, even after doing regular activity, even after that, the patient is having the sugar is more than 120, more than 126, or the postprandial is more than 200, you should start the drug. Know that, because immediately don't advise the patient to go with a metformin or any other oral anti-diabetic drugs, because it will because once you start the drug, the complication is the patient will be dependent. That is the problem. So once you start the drug, it doesn't mean that patient can be stopped immediately. What we see in our practice is some patients will be more interested to start the drug, but once they start, they'll stop taking it. So next side effect for most commonly with metformin is lactic acidosis. You could have seen patients with heart failure or patients with any other failures. We don't advise metformin because it will cause lactic acidosis. The next one is thiazolidine glitazone. Glitazone has nuisance racer. It is also nuisance racer in use nowadays. Next is pioglitazone. This is absorbed with 2 hours of ingestion. It may delay the uptake, but total bioavailability is not affected. It is metabolized to active metabolites. It is compatible with contraceptive pills metabolized by the same microsomal enzymes, and once a day before meals should be given at a dose of 15 to 30 milligram. It can be combined either with metformin or glimepiride.
வீடியோவே ஆனா ஓடலையே, எனக்கு சவுண்ட் மட்டும் தான் கேக்குது. சவுண்ட் மட்டும் உங்களுக்கு இங்கே
Rosiglitazone is
வேணாக்கா
predominantly
என்னோட
on
பெல்
PPI
மாதிரி
or
இருந்துச்சுல,
kappa, and rapid
அதை
absorption immediately
தொட்டீங்கன்னா
found is there.
சார் பேசுறது
Other
மட்டும்
properties are similar to the sulfonylureas. Most common side effect with
அதனால ஒரு பெல்
rosiglitazone is
வரும்.
there is fluid retention. Patients have more amount of weight gain
பெல் மாதிரி ஒன்று
along with
பண்ணுங்க.
anemia and headache and myalgia. It is not advisable when the patient is having CNS or CVS or hepatic complications without go with this drug. Alpha glucosidases are starch, oligosaccharides, and disaccharides, monosaccharides for absorption.
மியூட்
Pancreatic alpha
பண்ணிக்கலாம்.
limase like sucrose, maltose, glycoamylase, and dextrose are also been done. Alpha glucosidase are lactose. Acarbose inhibitor are competent inhibitor of the alpha glucosidase inhibitors, and meglitol is 6 times more potent than alpha amylase.
கவரேஜ் இருக்குன்னா லிஃப்ட் ஆகாது.
Dose for this meglitol and acarbose is 25 to 100 milligram is taken every
சாப்டர்
week
பெரிய சமைக்கல
and
இருக்கு
is
ஜாயின்
minimally
ஆகி.
absorbed. Produces flatulence, stool discomfort along with loose stools. So incretin mimetics, what is it? GLP-1 analogs and GIP analogs. Glucose-like peptide analogs, liraglutide and sitaglutide are being available. And GIP is gastric inhibitory peptide. These bind to the incretin receptor, which is being present and increases the insulin release. This is why we have been giving these drugs. That is GLP-1 analogs. So which what will happen? That attaches to the incretin receptors and increases the release of insulin. Drugs like liraglutide, exenatide can be given, and GLP-1 analogs are mainly resistant to the DPP-4 inhibitors. That will be explained in the next thing. This drug will cause weight loss along with GI side effects is the most commonly thing associated with this. DPP-4, that is vildagliptin, sitagliptin, tenligliptin, saxagliptin, linagliptin. So these drugs are being nowadays in practice. What I said, the remaining drugs are not being used more commonly, but commonly we use one is sulfonylureas, second one is metformin, and third one is this drug, dipeptyl peptidase 4 inhibitors. Never forget this, because these drugs will be added at an afternoon dose. If the patient is on metformin 2 grams and the patient is on glimepiride 2 mg, he will be in maximum 4 mg per day. Even after that, if the patient is not, sugar is not being reduced, the third drug of choice will be this DPP-4 inhibitor. We will be starting gliptins. because it has a very good effect in maintaining the postprandial glucose along with patients' nocturnal hypoglycemia, which is very less compared with to other drugs. So mainly for these patients, for diabetes patients, DPP4, that is either it can be vildagliptin, sitagliptin, saxagliptin can be preferred. So going with amylin analogs, this amylin is produced by the pancreatic beta cells, which mainly slows the gastric emptying and suppresses the glucagon. Prelimtinide is the amylin analog, and subcutaneous injection just before the meal and reduces the postprandial hyperglycemia. This is not being used commonly, but recent advances, amylin is being nowadays being under trial only. So these are the newer drugs which I said. This is called as SGLT2 inhibitors. This is nothing but sodium glucose co-transporter 2 inhibitors. It is also called as gliflozins. It is canagliflozin. Types are canagliflozin, dapagliflozin, empagliflozin, and etugliflozin. But most commonly we don't advise for all patients because it's very costly. Because those patients who are not willing to take insulin, they'll be preferably going with these gliflozins. But more commonly nowadays they're having side effects. So these are being avoided in many reasons, because they'll be having mainly for females, they'll be ending up with a urinary tract infection. They'll be having some vaginal infections, so more prone for vaginal infections. Some patients are also being complaining about joint pain. But these are being also used when the patient is not they're not willing for taking insulin. Canagliflozin, dapagliflozin can be used. So these are all the oral hypoglycemic agents. But for you, you should note only 3 drugs mainly. That is, first is metformin, that is a golden drug, and second one is sulfonylureas. What we use sulfonylureas are glibenclamide, glimepiride, and gliclazide. So the maximum dose for glimepiride is 2 milligram, that is 4 milligram per day, and the maximum dose for metformin per day is 2 grams. And even with these 2 drugs, the patient's sugar is not under control. Third drug of choice will be DPP4, that is dipeptide peptidase 4 inhibitors, that is called as either vildagliptin, sitagliptin. That can be given for preventing nocturnal hypoglycemia. So after all these drugs, the patient's sugar, even after that, they're not maintaining proper diet, they're not having proper activities are not there, and even after that, the HbA1c is more than 10 or more than 8, definitely the patient should be started on insulin. So I'll be dealing about what are the types of insulin and what you see in the practice, and how to store the insulin and how the insulin has to be delivered. I'll be discussing the next slides. The basics of insulin therapy is first of all, insulin was first of all found by who? They're Banting and Best. You can see a dog in that image, I guess. So first of all, this is the best investigation that was done, best drug that has been found to control the diabetes at present. The dog was the god for insulin, because depending on the insulin was first taken from the dog, and till now we are bringing that only. So Banting and Best was the one who discovered insulin. So going with the types of insulin, nowadays we used to go with basal insulin and the meal insulin. So what are the types of insulin? You would have seen insulator, humulin in your practice, right? So that is called as intermediate acting, and long acting drugs are glargine, that can be having that is Lantus, what you use the brand name, and glargine is again another brand which you have, the detima degludec. So long acting is glargine, detima degludec, whereas intermediate acting is NPH, that is called as neutral protamine hexadone. That is a full form. In your practice, you'll be seeing either insulator and this Lantus or Besseler or Levimir. So this is NPH. So this is the insulin what you're going to have, and this is glargine, which is a pen form. Nowadays we use being going with the pen form of insulin. It is a basal insulin, and this is also glargine. So meal insulin, this is what you'll be doing in practice, right? Regular insulin, Actrapid. You'll be giving Actrapid for all the patients, right? So when you'll give Actrapid, so Actrapid has a very short acting, and long acting is again Lispro. Rapid acting is Lispro, Aspart, Gluglycin, and short acting is Actrapid. So I'll be telling you about how the duration of actions of each insulin occurs. These are all the images. Premixed insulin, it can be combining of both insulator along with Actrapid, that is 70/30, or even only with the Aspart, that is Aspart is Gluglycin with Actrapid. So we have mixed forms, that is it can be either mixed or no mix, or only rapid acting with intermediate acting. These are all the combinations that are available. So when you will start on insulin, that is the basic thing, right? What I said, patients going with HbA1c of more than 10, and patients are having after anti-diabetic drugs, after starting all the anti-diabetic drugs, even after the patient's sugar is not under control, and the patients who are having active infections, that is more important. You can see in your practice, patient will be having an ulcer, patient will be having cardiac complications, patients who are admitted in ICU, they need only insulin because anti-diabetic drugs has no role for them. You may need, along with insulin, you'll be needing some other anti-diabetic drugs, but insulin is the treatment of choice when a patient is having active infection. So first of all, 12 units of insulin in a 0.5 ml syringe. In a 100 unit syringe, the line next to the 10 is 20. Like that, you have to go accordingly. When injecting 12 units, you draw one line after the line 10. So that signifies the patient is having 2, 4, 8, 10, and 20. It comes like that. Okay. So always go accordingly depending upon the insulin syringe. Insulin syringe has a very important role. So you can't deliver a large amount of insulin in a 0.5 ml. Okay. Don't take 2 to 3 picks in having a, just imagine you have to deliver around 20 units. You can't do with the 0.5 ml syringe, right? So always go with a better insulin, better syringe. Insulin pens, these are all the types of pens that is being used nowadays. It can be either reusable pens along with disposable pens. Actually. Okay. So the insulin pens. So what are the types of pens nowadays? These are the common practice. Before 5 to 10 years, it was only what you used to take a vial, you have to load the vial, and you have to deliver the insulin. But nowadays, it has a patient. It has all become patient friendly, so they can deliver by themselves, right? So these are the types of pens. It can be either reusable pens, it can be either disposable pens. Reusable pens, that is cartridge has been changed. Disposable pen, the whole pen is changed. Keep always new disposable pen or cartridge in refrigerator. That is more important. Once the pen or cartridge is open, keep it in room temperature because the validity depends upon the type of insulin pens. How you should take the pen care for insulin. The insulin pens must be stored at room temperature. Storing your insulin pen in extreme temperatures can lead to changes in the concentration of the pen's insulin. Do not share your insulin pen with anyone because even if you change the needle, because infections like HPV, HIV has happened, the insulin itself can be contaminated. Do not withdraw insulin from a pen cartridge. That is more important because it can lead to inaccurate dose measurement the next time the patient the use for dose delivery. The reason for this is it is related to air entering the pen unintentionally, interfering with the proper mechanism. Do not leave the open needle attached to an insulin pen. It can lead to unintentional air entering into the insulin pen, and ultimately improper dosing of insulin can occur, and it can also lead to insulin contamination. Proper insulin pen mixing, that is, every time use a pen containing this insulated or pre-mixed mixtures like no mix or mixed, the insulin should look uniformly cloudy or milky after mixing. That is more important. Okay, if there are clumps floating in the insulin or white particles stuck to the bottom or sides of the pen giving a frosted look, never use that. Okay, that is more important. So how long is the pen, open pen or unopened pen outside the refrigerator valid for? In case of the rapid acting like aspart, disproglucin, till 4 weeks it can be used. Whereas NPS like insulator, what you're being using it, insulator, it can be kept for 2 weeks. Glargine, Detimer, Degludec are all long acting. It can be stored for up to 4 to 8 weeks. And aspart is mixed, that is a mixed form. It can be given kept for 2 weeks. And pre-mixed insulin like 70-30, that is Nomix 70-30 or Lispro 75-25, it can be stored for up to 10 days. So these are all the duration for how long the insulin can be kept. So where you give the insulin, this is the more important thing. What we don't do in practice regularly. Always you give in the same site, right? You will be giving in the same part of the body, so the patient will be having some side effect because they'll be having some skin infections in the giving in the same site. So always give in a rotation manner. Okay, more preferably the umbilical region, around the umbilical region and abdomen is the more preferable site for insulin. But the patient is not cooperative, go with other sites. So these are all the site for insulin injection. Always rotate the injection site. That is more important for having a proper insulin action. So what time to give the insulin? Insulator, you would have seen. Usually it will give insulator right at BD dose. That is NPS. These are intermediate acting, which will be acting for about 24 hours. Also, it can be having it can be acting for about 8 to 12 hours. So always at preferable time is given at bedtime, or it can be given either at morning and BD dose. This is how you would be giving insulator. Whereas glargine detimer, that is sometimes some patients can be needing it twice, but more preferably will be giving it night dose. Degludec is also once daily at the same time of the day. So what time for regular insulin? That is Actrapid. When you will give Actrapid, usually give Actrapid at before half an hour, right? So 30 minutes before meal should be given. It should be given. It depends upon the patient's insulin dosage. It can be given at once, twice, or 3 times a day. And rapid acting insulins or ultra rapid acting is like Nova Rapid is there. Many other brands are there. So those things should be given 5 minutes because they're rapid acting. If you give before 30 minutes, the patient will go into hypoglycemia immediately. So when you give rapid acting, ask the patient to take food immediately after delivering the insulin. That so that you can prevent hypoglycemia. What time to give insulin? In case of premixed like Mixtard or Humulin, 30 minutes before meal can be also given at once or twice or 3 times also. Some depending upon the patient's requirement of insulin, it can be given up to 3 times a day. Whereas Aspart and Lispro, 75, 25, and 50, 50, it should be given because it is also having a rapid acting, ultra rapid acting is available in this. So that always give 5 minutes before the meal. So which insulin to use? How will you define? How will you find out what insulin to be needed for the patient? So depend upon the glucose control. As I said, depending upon the HbA1c. If the patient's HbA1c is more than 10, for this more, and patient is requiring of anti-diabetic drugs of more than 3 drugs, he is already on 3-drug regimen. Even after that, the patient's sugar is not under control. Definitely, the patient needs insulin. But preferably, we prefer insulin to use not in younger patients because very engaged at around first newly diagnosed diabetes. Nowadays, in practice, some doctors are preferring for insulin, but in practice, better to start with anti-diabetic drugs. And after that, even if the control is not properly maintained, go with insulin. Always go with the protocol. That is more important. And depending on the patient characteristics, certain patients they'll be very busy. They'll be having a high, very high professionals be there. There'll be lifetime modifications very difficult for them, and they can't take medicines at a proper time. And they'll not have a proper diet. Just imagine being in a very busy schedule. It is very important to maintain the sugars, right? So those patients we don't have other go. They have to go with insulin only. Another lifestyle modification. Sometimes patient they, as I said, because of the busy schedule, they'll not be able to take the drugs at a proper time, right? So depending upon the preference of the patient, we can start on insulin. So we will give basal, that is basal long acting, as I said, it is given at a bedtime dose. At night before after going sleep, before going to sleep, patient will take a basal dose. The next regimen is again basal intermediate acting. It can be also given at a bedtime dose. Whereas basal intermediate, if it is given as a twice a day dose, given as before breakfast and after having a food at a bedtime. This is what we commonly use, right? You will be giving Actrapid, that is rapid acting will be given TDS along with the insulator, that is the intermediate acting will be given at BD dose, right? So some patients will be requiring rapid acting TDS and basal insulin, so that is NPH will be requiring at the BD dose. And this is again one basal plus 2 meals. Third regimen. There are many regimens because it doesn't mean that this patient should go with this regimen and this another patient should go with this one. It is not like that because each and every patient varies. So depending upon the fasting level and depending upon each and every glucose level, we'll be defining how to start the insulin. Not just a newly diagnosed patient, immediately you can't start with the basal. Newly diagnosed a patient having poor control of the glucose, you can't start with the regular insulin alone. You have to go with the basal. So depending upon the patient's glucose level, we'll be deciding how to deliver the insulin. So depending upon the insulin requirements, I'll show you one thing. This is the commonest thing what we'll do. So you'll be doing this, right? Actrapid, what I said, 2 intermediate acting and with 2 meals. That is, a patient will be having a regular insulin along with intermediate insulin. And at night time also, you'll be having a regular insulin along with intermediate insulin. The regular insulin, what it does, it mainly reduces the immediate hyperglycemia what he's going to have. And patient, while he's going to sleep, what he needs the sugar to be maintained control, right? So that is why you'll be giving an intermediate acting because it has a prolonged duration of action. It has up to 12 hours. So during that time, the patient should not go into again hyperglycemia. So that time, because of that, we'll be preferring 2 intermediate plus 2 meals. This is the most preferred thing when you start a patient with an insulin regimen. And this is the depending upon the patient's requirement again. If the afternoon glucose is also more, we'll be going with 2 intermediate with 3 meals. Depending upon the meals, for each and every meal, before each and every meal, we'll be giving a breakfast because but in lunchtime we don't give insulator. Why? Because it has a longer duration of action. The patient end up with hypoglycemia at night time. So always don't go with insulator at the afternoon dose, but morning and night it is preferably given along with a TDS dose of the regular insulin, that is Actrapid most commonly being given. These are all the various regimens that is being used nowadays. I hope these insulin regimens are given you some idea how to use the insulin. Mainly for you guys, you have to check. Most commonly what I see in practice is these patients, the needle will not be properly changed, and the proper delivering will be not be there, and moreover, they will not be knowing whether the patient's having insulin or not. Simply, they'll be using the insulin pens without knowledge. So always guide them before delivering each and every time. That is the more important thing in controlling a sugar in a diabetes patient. So always, once if you start the insulin, add a anti-diabetic agent. More commonly with insulin, what drug you would have seen? Today's patient having insulin, the only drug what we prefer is to give is metformin. So metformin, because it doesn't cause hypoglycemia. If you add any other like sulfonyl glimepiride, glibenclamide, if you add insulin with the glimepiride, glimepiride, patient going to severe hypoglycemia. That is the most drastic, dangerous condition. So never advise patient to go with insulin plus sulfonylureas. Insulin with metformin is better because it increases the insulin sensitizer. So always preferred drug is insulin along with metformin. Thank you. Okay, if you have any doubts, you can ask me. No, that's it.
Thank you, dear friends, for your patient listening. Hope you have gained some amount of knowledge through Dr. Arvind for his from his speech as such. Now we will go on to the next session by Madam Sharmila, who's associate professor in our college. She'll be, telling you in a nutshell about diabetic ketoacidosis. Over to Sharmi, please.
Good morning to all. Today I'm going to deal about the diabetic ketoacidosis. Diabetic ketoacidosis is the state of absolute or relative insulin deficiency that can be aggravated by the hyperglycemia, dehydration, and acidosis that can be produced by the dearrangement in metabolism. So what will happening if there is any insulin deficiency or if there is a decreased tissue sensitized to the insulin, that time what will happen, will be increasing in the hyperglycemia. So because of hyperglycemia, what will happen, the increased glucose level in the blood, so that can be Yes. In diabetic ketoacidosis, there will be a absolute and relative insulin deficiency. There will be hyperglycemic dehydration and acidosis that can be produced because of dearrangement in metabolism. If there is any insulin absence, or if it is a decreased tissue sensitized to the insulin, that time what will happen? Hyperglycemic. Hyperglycemic increase on the glucose level, or excessive and the glucose will be excreted through the urine. So at the same time, along with the water and electrolyte sodium kuda vandu there will be excreting, so that leads to the dehydrations, and because of hyperglycemic, and then there will be a glyconeogenesis, glycolysis adella vandu, and lipolysis nala at the end product of ketones bodies will be producing, that can be make it as the acidosis. All this can be happen because of dearrangement in metabolism. In diabetic ketoacidosis is mostly characterized by hyperglycemia, low bicarbonate, acidosis, ketonemia, and ketonuria. Hyperglycemic the blood glucose level more than 300 milligram per deciliter. Bicarbonate, low bicarbonate normal 20 to 26 milli equivalent per liter, but in the diabetic ketoacidosis there will be less than 15 milli equivalent per liter bicarbonate. Acidosis pH level 7.30 normal 7.35 to 7.455, but in this decay acidosis level less than 7.30, and the ketone bodies like acetoacetate, acetone, and beta hydroxybutyrate will be increased in the blood and urine. That's why we will have the ketonemia and ketonuria. So diabetic ketoacidosis is characterized by hyperglycemia, low bicarbonate, and acidosis, and ketonemia and ketonuria. In causes of diabetic ketoacidosis, first one, the insulin deficiency. If it is insulin deficiency, what will happen? We will have the increased glucose level in the blood, and there will be increased counter-regulatory hormones. If it is a decrease in the insulin deficiency, counter-regulatory hormones like glucagon, cortisol, growth hormone, epinephrine, இதெல்லாம் increase ஆகும். So இதெல்லாம் என்ன பண்ணுதுன்னா, it will be it will be increasing the glucose level, and osmolality changes will be happen. அடுத்து enhanced hepatic glyconeogenesis, glucogenolysis, and lipolysis. The gluconeogenesis and glucogenolysis there will be increase in hyperglycemia. At the same time, if lipolysis there will be end product will be the ketone bodies. Already I told you, acetoacetate, acetone, and beta hydroxybutyrate will be increase in the body. அடுத்து இந்த ஹைப்பர்கிளைசிமினால என்னென்ன சேஞ்சஸ் வரும் அப்படின்னு பார்த்தீங்கன்னா, there will be uncontrolled hyperglycemia, asthmatic diarrhea, already before I told you. So if it is hyperglycemia இருக்கிறப்ப அந்த osmotic changes இருக்கிறனால there will be more, and the urine, along with the urine, the water and sodium and glucose will be excreted. So because of excessive and the diuresis irukanaala, we will have the dehydration. Because of dehydration, the renal impairment can be happen for the patients. And excessive lipolysis there will be increased free fatty acids will be in the liver. So increase free fatty acid liver that will be increasing the oxidations in the liver. So adala end product and the free fatty acid end product will be accumulation in the body, that can be change the buffering capacity, that can be lead to the acidosis. And pathophysiology in diabetic ketoacidosis, first one, if there is increased in the lipolysis and triglyceride breakdown, there will be increased free fatty acid will be in the plasma, and that can be increased in the liver also. So if the liver free fatty acid increase, that can be stimulate the ketogenesis, that will be increasing the ketogenesis in the free fatty acid will be metabolized, and that can be end product acetoacetate, acetone, beta hydroxybutyrate, the ketone bodies produce பண்ணும். So in the ketone bodies will be increasing in the circulation, that can be excreted through the ketonuria ஆகும். Ketonemia, ketouria and ketonemia ஆயிருந்தால, so this can be changed, our alkaline and the change ஆகி, that can be lead to the acidosis. At the same time, if it is increased in the proteolysis, and the protein tissues la irukra protein வந்து lysis ஆக ஆரம்பிக்கும். அந்த மாதிரி ஆரம்பிக்கிறப்ப வந்து நம்ம we will have the plasma amino acids will be increased, that will be stimulating the gluconeogenesis. That can be amino acid will be metabolized. அது வந்து gluconeogenesis மூலமா வந்து we will have the end product, we will have the hyperglycemia. So already before I told on the hyperglycemia ஆகிறப்ப வந்து we will have the next வந்து osmotic diuresis will be happen. So அதனால வந்து dehydration வரும், that can be impair the renal functions, and later it can be changed as the acidosis. At the same time, another thing also happening, decreased glucose uptake இதனால தான், and because of the increased amino acid in the liver and fatty acid, அது வந்து என்னன்னா we will have the gluconeogenesis வந்து stimulate பண்ணி we will have the increased glycemic productions will be, and the end product of the metabolism வந்து glycemic வந்து நமக்கு கிடைக்கும். அப்போ வந்து நம்ம வந்து it will be making as the hyperglycemia ஆனாலே again we will have the glycosuria, and that might lead to the osmotic diuresis, and along with the diuresis ஆகிறப்போ we will lose the electrolytes also. So cellular வந்து dehydrations will be happening. So the volume depletions ஆகிறனால again we will have the renal functions will be impaired, and that can be lead to the acidosis. So here இந்த பிக்சர்ல பாத்தீங்கன்னா, so ஒரு இதுல வந்து புரோட்டீன், அந்த மசில்ஸ்ல இருக்கிற புரோட்டீன் வந்து அமினோ ஆசிட்ஸா வந்து டைவர்ட் ஆகி அது வந்து it will be entering into the liver. அதே சமயம் அடிப்போஸ் டிஷ்யூ இருக்கு இல்லையா, அதுவும் ட்ரைக்ளிசரைடு வந்து லைசிஸ் ஆகி that can be releasing the glycerol and free fatty acid. இந்த கிளிசராலும் இந்த அமினோ ஆசிட் வந்து it will stimulating the gluconeogenesis, and along with the glucogen in the glycate 6-phosphatase வந்து சேர்ந்து it will be metabolized, and that will be giving the glucose as the end product. So if it is more production of glucose, we will have the glucose hyperglycemia will be there. So அதனால osmotic diuresis and volume depletion, dehydration and renal impairment, and we will have the acidosis. At the same time, in the triglyceride and adipose tissues la irukka fat and lipids வந்து lysis ஆகிறப்போ வந்து glycerol and free fatty acids வந்து இருக்கு இல்லையா, அந்த free fatty acid வந்து metabolize ஆயிட்டு அதோட end product வந்து ketone bodies, acetoacetate and beta hydroxybutyrate வந்து produce பண்ணும். அது வந்து ketone bodies that will be making as the metabolic acidosis change ஆயிடும். Okay, அதே மாதிரி இந்த free fatty acid வந்து என்னன்னா it will stimulating the prostaglandin I2 and prostaglandin E2 வந்து stimulate பண்ணுது. Prostaglandin I2 வந்து it's making us the vasodilations. அதே மாதிரி prostaglandin E2 வந்து stimulating the gastric இதுல வந்து stimulate ஆகி decrease acid secretions ஆகும், and gastric இதோட contractility வந்து அதிகமாகும். vasodilation contractility அதிகமாகும், அடுத்து decrease வந்து acid secretions கம்மி பண்றதுனால what will happen, there will be decreased vascular resistance will be there, along with இந்த இது contractility இதெல்லாம் இருந்தனால we will feel the nausea and vomiting, and we will have the abdominal pain. So in the pathophysiology, muscles la irukra protein வந்து metabolize ஆயிட்டு amino acids வருது, adipose tissues la irukra வந்து triglycerides வந்து metabolize ஆயிட்டு glycerol and free fatty acid தருது. இந்த glycerol and amino acid together making us the gluconeogenesis, and it is giving the end product of glucose that lead to the hyperglycemia, that lead to the osmotic diuresis, and that lead to the volume depletions and dehydrations, and it making the renal impairment. அதே மாதிரி free fatty acids will be metabolized and giving the end product as the ketone bodies, and the free fatty acids stimulating prostaglandin I2 and E2 இதை வந்து stimulate பண்ணி it making us the decreased vascular resistance, and the patient will feel the nausea and vomiting and abdominal pain. And next we'll see the signs and symptoms of diabetic ketoacidosis. The patients will have the increased thirst, அதாவது பாலிடிப்சியா இருக்கும். அடுத்து வந்து increased urination will be there. அடுத்து வந்து the patient will feel the nausea and vomiting. They will feel a generalized weakness and fatigue will be there. அடுத்து altered consciousness, mostly the patient will go to the also. அடுத்து வந்து signs of dehydration, like the patient will feel cold clammy will be there. அடுத்து the patients mainly வந்து they will have the acetone odor breathing. அதாவது acetone breathனா அந்த breathe பண்றப்போ வந்து நமக்கு வந்து அந்த fruity scent அந்த இது வந்து ஸ்மெல் வந்து இருக்கும். The patients if they breathe acetone odor, breathe இருக்கிறப்போ fruity scent smell வந்து will be there in the breathing. அடுத்து வந்து they will have the signs of acidosis. Signs of acidosis like a shallow rapid breathing or air hunger. அதாவது we are calling as the Kushmal or sighing respiration. இதுல மெயின் என்னன்னா they will have the deep breathing. அடுத்து வந்து அதாவது எக்ஸ்ஹேல் பண்றதுக்கு முன்னாடி they will start the next breath. The patient will have the long and deep breathing. Before exhalation they will start the next breathing, that is the Kusumal breathing as sighing respirations, and the patient will have the abdominal tenderness, and they will have the signs of intercurrent illness. Intercurrent illness is that they will feel like a thirst, they will have the dry mouth, and they will passing more urine. These are the signs and symptoms of diabetic ketoacidosis. And next we'll see the diagnostic evaluation. First urine test we have to check with the dipstick they will have the positive glucose and ketones will be there. In blood and plasma we have to check the glucose more than 300 milligram per deciliter ஆயிருக்கும். Sodium we have to check the sodium because when we will be excreted through the urine வழியா glucose excrete ஆகிறப்போ along with the water and sodium also will be excreting. So the patient will have the sodium level will be less. That normal விட 1.6 milli equivalent per liter reduce ஆக chances. That normal level is the 135 to 145 milli equivalent per liter. And we have to check for the bicarbonate. Bicarbonate less than 15 milli equivalent per liter. Normal is the 22 to 26 milli equivalent per liter. And we have to check for the potassium. Mostly the patient will have the hypokalemia. Normal is the 3.5 to 5.0 milli equivalent per liter. And we have to check for the complete blood count, RBC, WBC, and the differential counts, everything we have to check. At the HL blood gas analysis, we have to check for the pH level. pH will be less than 7.3. Normal our pH level is the 7.35 to 7.45. At we have to check for the phosphorus. Mostly we will have the hypophosphorus the patient will have in the diabetes patients. Normal level is the 2.8 to 4.5 milligram per deciliter. And we have to check for the amylase. Mostly the patient will have the hyperamylasemia. Normal is the 30 to 110 unit per liter. And other diagnosis tests like we have to do the ECG. ECG la hyperkalemic changes அதிகமா இருக்கும். அதாவது we will have the tall weak T waves இருக்கும். Prolonged QT intervals prolonged இருக்கும். And we will have the QRS complex will be widening. Tall T waves and prolonged QT intervals and widening of QRS complex will be there in the changes of hyperkalemia. Chest X-ray we have to rule out whether the patients have any pulmonary infections, because there is diabetic patients there are more chance of getting the infections. Mostly in the pulmonary tuberculosis and pneumonia the chances are, so we have to check for the any pulmonary infections there. அடுத்து culture to identify the any causative organism. This can be help our to treat the based on the organism தகுந்த மாதிரி நமக்கு antibiotic administer பண்றதுக்கு it will be helpful. And imaging study we can see the cerebral edema changes, because in the osmotic change intracellular to extracellular fluid shift இருக்கறனால mostly the patient will have the cerebral edema can be chance. So we have to rule it through the imaging study the cerebral edema. And we have to look for the comorbidities. Comorbidity mostly in the concomitant infections, all the places we will have the infections, especially urinary tract infection is the most common infection for the diabetic ketoacidosis patients. And we have to check the missed insulin treatments that will be 25% patients will have, and 50% of patients they have the previously unknown diabetes, and 20% of patients they have the other associated causes like myocardial infarctions or any cerebrovascular accident, any complicated pregnancy, trauma, stress, and surgery. This can be comorbid conditions. And management part, first if the patient have DKA, first 24 to 40 hours we have to keep under ICU or acute care bed. It is advisable. And we have to do the fluid resuscitation. And another modalities is the insulin therapy and potassium supplements. And we have to correct the acid-base balance, and we have to treat for the concurrent infections. First, we will see the fluid resuscitation, because we have to give the intravenous solutions to replace the extravascular and intravascular fluid la the electoral losses irukanaala we have to replace the fluid. At the same time, if you are administering the fluid and the resuscitations பண்றப்போ we can dilute the glucose level, and also we can the circulating and the counter regulating hormones level we can able to manage. So first half an hour we have to administer 1 liter of fluids. 1 liter of fluids we have to administer, and next second and hour 1 liter. First half an hour 1 liter, and second hour we have to administer the 1 liter, and next we have to for the 2 hour duration we have to administer the 1 liter of saline. அடுத்து 1 liter of saline for the every 4 hours. That can be dependent on the CVP. We have to monitor the central venous pressure, that have to be monitored. After that only we have to administer, whether we have to administer if fluid overload ஆகாம இருக்கணும். Fluid overload that can be lead to the some other complications. So we have to monitor the central venous pressures, and based on this we have to administer the replace the fluid therapy. First half an hour we have to administer 1 liter of saline, and second hour we have to administer only 1 liter, and followed that we have to for the 2 hour duration we have to administer 1 liter, and every 4 hours we have to administer the 1 liter based on the central venous pressure. அடுத்து we have to monitor the patients ஓட the volemic state பார்த்துட்டே இருக்கணும். அந்த evolemic state அந்த மாதிரி வந்துட்டாங்கன்னா, அத if the patient is அந்த hypernatremiaக்கு போயிட்டாங்கன்னா we have to change the isotonic sodium chloride solution normal saline we have to change it as the half normal saline change பண்ணிடுறோம் in case of hypernatremia இருந்தா. அதே மாதிரி we have to monitor the glucose level every 2 hours பார்த்துட்டே வரணும். up to 2 hours பார்த்துட்டே இருக்கிறப்போ if the patient got 180 milligram per deciliter ஆயிடுச்சுன்னா that time we have to change normal solution இதுல இருந்து we have to change 5% to 10%, 5 or 10% of half normal saline we have to administer the patients. If the evolemic state now we have to change as the normal saline to half normal saline. If the blood glucose level is reduced as a 180 milligram per deciliter ஆயிடுச்சுன்னா we have to change to 5 or 10% of dextrose with half normal saline. And next is the insulin therapy. So low dose குடுக்குறப்ப hypoglycemia, hypokalemia we can prevent. But in case of diabetic ketoacidosis இருக்கிறப்ப patient will be on the dehydrations. அப்ப அந்த dehydration stateல இருக்கிறப்ப subcutaneous insulin கொடுத்தோம்னா that cannot be absorbed proper absorb ஆகாது. அதனால என்ன பண்ணனும்னா we have to administer the IV or IM. Better we can go with the IV infusions. So IV infusions கொடுக்கிறப்ப என்ன பண்ணனும்னா the starting rate we have to start 0.1 unit per kg per hour start பண்ணனும். So how we have to prepare the insulin infusions? If you have the infusion pump இருந்துச்சுன்னா 60 ml of normal saline 24 units of insulin mix பண்ணிட்டு அத 15 ml per hour we have to administer. Okay, அதாவது 6 units per hour administer பண்ணனும். அதே மாதிரி நம்ம every 2 hours, even if you are giving the insulin therapy, fluid therapy, we have to monitor every 2 hours the glucose level. If it is glucose level 180 milligram per deciliter ஆயிடுச்சுன்னா, so we have to, if less than அந்த மாதிரி 180 ஆயிடுச்சுன்னா, we have to reduce the dose to 5 to 7.5 ml per hour, or we have to reduce the dose of 2 to 3 unit per hour until the ketoacidosis clear or we have to give. In case of if you not have the pump normal pump infusion pump available illada samayathil we can use the 500 ml of normal saline 60 units of insulin mix panni we can give 550 cc per hour we can give with a microtrip. If we are not available with the infusion pump, so we can go with a normal microtrip vachu 500 normal saline 60 units of insulin add panni 50 cc ml per hour we can administer. அடுத்து already I told you இந்த இதுல diagnosticல hypokalemia இருக்குன்னு சொன்னோம் இல்லையா. So we have to say that whether if the patient the potassium level is 6 milli equivalent per liter இருந்துச்சுன்னா no need of giving a potassium supplements. If the patient potassium level is 4.5 to 6 milli equivalent per liter இருந்துச்சுன்னா we have to administer 10 milliequivalent per hour of potassium chloride we have to administer. If the potassium level is 3 to 4.5 milliequivalent per liter இருந்துச்சுன்னா we have to administer 20 milliequivalent per hour வந்து we have to administer the potassium chloride. And every hour வந்து if you are administering the potassium every 1 or 2 hour வந்து we have to check the potassium level. If the administration பண்ணிட்டு இருக்கப்ப in between and 1 or 2 hours check பண்றப்ப if the level is the 5 milliequivalent per liter அப்படியா இருந்துச்சுன்னா we have to stop the potassium supplements. அடுத்து வந்து we have to do the correction of acid base balance. Acid base balance வந்து we have to administer the sodium bicarbonate. Sodium bicarbonate கொடுக்கறப்ப வந்து we can be able to decompensate the acidosis. Acidosis வந்து decompensate பண்றதுக்கு especially in the case of sepsis and lactic acidosis இருக்கிறப்ப வந்து we have to administer the soda bicarbonate. Soda bicarbonate வந்து 100 to 150 ml of 1.4% concentration வந்து initially administer பண்ணணும். அடுத்து வந்து if we need we have to repeat after half an hour. The treatment of concurrent infections. If the patients have the after culture we have to administer the antibiotic based on the sensitivity ஏத்த மாதிரி administer பண்ணனும். But அதுக்காக up to the culture result வர வரைக்கும் no need to wait. We can start any antibiotic for the patients. And next we'll see the complications of diabetic acidosis. First one is the cerebral edema. Why most of the pediatric patients, we will always have the cerebral edema with very poor prognosis. Why means if we because of the in the osmosis shift fluid shift nala there will be intercellular extracellular shift nala we will have the cerebral edema and we will have the hypokalemia. Fluid replacement therapy it will be dilute and we will have the hyperkalemia. Hyperglycemia, when we will start the insulin therapy நம்ம கொடுத்துட்டே improper checking the glycemic இது பார்க்காம இருந்தோம்னா there is chance of getting the hypoglycemia because we are administering the IV infusions every 2 hours we have to check. If you are not properly monitoring there is chance of patient getting complication like hypoglycemia. And acute pulmonary edema because fluid resuscitations பண்றப்ப there is chance of getting the pulmonary edema. Fluid overload ஆகறனால there is chance of getting the pulmonary edema. And other complications like we can chance of getting the cerebral venous thrombosis because of cerebral edema இருக்கறனால the stagnations and the fluid and the changes நால there is chance of getting the thrombosis. And myocardial infarctions and acute gastric dilatation and erosive gastritis and late hypoglycemic also and respiratory distress and infections. These are the complications we are getting because of diabetic ketoacidosis. And next we'll see the prognosis. Prognosis if the patient at the time of diagnosis, when they got admission on the time the patient came with a deep coma, hypothermia and alicuria signs oda admit ஆனாங்க diagnosisல இந்த signs எல்லாம் இருந்துச்சுனா they have the poor prognosis. Thank you. Do you have any doubt? If you have doubt you can put it in the chat box. So today's section is over, and tomorrow we will have we will meet with the other sections. Okay, thank you.
Dear participants, hope you would have been listening to Sharmila Madam as well as Dr. Arvind for today's session. Tomorrow, we will be having 2 sessions by doctors. One is diabetes in pregnancy by Dr. Janita and diabetes retinopathy by Dr. Meena. We will also having a small demonstration on foot care by Miss Shruti. So we look forward to your presence by tomorrow morning by 10:30 a.m. Okay, and the very next day will be the last day where we will have an adaptive nephropathy following a quiz. So we will look on to your participation for the next 2 days. Thank you.